Right, welcome back. It's sort of the finale, and it is my great pleasure to introduce a friend and a colleague and a very distinguished academic, clinician and a policymaker who is Sir Mike Richards. Now, most of you will know, have heard of him, have seen him either in the newspapers or television. I've had the privilege of knowing Mike for a long time. Certainly in the early days that I got involved in policy. He's a man who transformed cancer services in this country with his seminal report back in the year 2000, which was the National Cancer Strategy and the framework he put together. And there's no question, whichever way you look at it, the transformational change and the speed in which he managed to achieve that in the UK has been the envy of many, many countries. I remember it was about mid-2004, 2005, where I happened to visit the US, and Memorial Sloan Kettering were proudly saying we're about to start multidisciplinary meeting, when I had the great pleasure of telling them that this is one of the greatest achievements in England, and about somewhere in the 90% in those days, patients who have cancer are discussed in multidisciplinary meeting. So that's one of many, many examples, and there's no doubt he fought some very, very hard battles. His influence, his very unique set of skills in managing even, within the presence of the ex-president of the Royal College of Surgeons, disgruntled surgeons in whom their services are going to be centralized to a single site, done with the least amount of noise possible, and had a huge impact, whether that was esophageal cancer, hepatobiliary pancreatic cancer. Anyhow, he survived many politicians, many secretaries of states, and eventually I think the NHS was lucky enough, after the big scandal of mid-staff, that they recognized a clinician, and certainly from my perspective, I remember these debates at the time, a clinician should be the chief hospital inspector. And it was, you know, my great pleasure, and many clinicians who've known Mike, but actually who work within the NHS, when they heard that Mike has been appointed in 2013, and since then he's done a remarkable job in transforming many hospitals. I think the deterrent factor also has a huge impact. And he's done it again with the right values, with the right principles, and won the clinical confidence and the frontline staff confidence. And he's going to share with us some of his thoughts of the work he's been leading in recent times. And again, Mike, we know how busy you are, so thank you for your time, and it's all yours. Thank you. Could you please welcome Sir Mike Richards.
Ara, thank you very much indeed for that extremely generous introduction. Just briefly on the subject of multidisciplinary teams, probably the thing that I am proudest of is having written a paper or a report on why we should have multidisciplinary teams back in the early 1990s. But then, and Norman, you'll forgive me for saying this, it was the moment when I was at a meeting with colorectal surgeons, and I asked them whether they worked in multidisciplinary teams, and they all said yes, and they all told me they always had. This was totally untrue, but the fact that they thought it was true was what really mattered. And so at that point we knew that was really firmly embedded. So, something quite different now. What about safety and quality, particularly from a hospital perspective, and to give you some insights from the new CQC inspection program. And this program really only started, well, I was only appointed and took up post 14 months ago, with a message very clearly coming from the Secretary of State, please get started as soon as possible, in other words, within 1 to 2 months, and please get round all the hospitals in England before December 2015. So that was the challenge. What is the CQC? Well, the CQC is the regulator of health and social care. So it crosses the patch. It's also very important to say we inspect and regulate both health service and the independent sector. So we make sure that health and social care services provide people with safe, effective, compassionate, high quality care. We encourage them to improve. We are not an improvement agency per se. That's for other people to do. But we very much hope that we are an agent for improvement. In other words, I and my colleagues wouldn't get out of bed in the morning to do this if we didn't hope and believe that we could really drive improvement. How do we do it? We do it through monitoring, inspecting, regulating. First of all, to make sure that people achieve fundamental standards. But we go far beyond that now. And this is one of the things that's new about the programme. We're also looking for what is good or outstanding. And that's where the ratings come in. And I'll talk more about those. So we are trying to look across the whole spectrum. And in any service that we look at, and this doesn't matter whether we're talking about a care home, we're talking about a general practice, or we're talking about a service within a hospital, we are asking 5 questions. Is it safe? Is it effective? Caring? Responsive? Well-led? Now, those words trip off the tongue quite easily. The devil is in the detail. The question is, what do we actually mean by those and what lies behind it? So sort of one stage of definition is safe is about protecting people from harm, from abuse and avoidable harm. One, first do no harm. In other words, when I come into hospital, please don't make me worse. Please don't let me fall out of bed unnecessarily. Don't give me a pressure ulcer. All of those things. Don't take the wrong leg off or whatever it may be. Effective. And actually, I think with effective, it's something that a lot of hospitals haven't focused on sufficiently. Because the next thing after saying, please don't make me worse, is to say, please make me better. And it's surprising how difficult it is for hospitals to demonstrate to us where they are on an effectiveness spectrum. And we'll come back to that. And so that's about making people better. Our definition of caring is really about the human-to-human interactions. The nurse to the patient, the doctor to the patient, the receptionist to the patient. Is that done with compassion, dignity, and respect? Responsive, which we separate out, and quite often within the sort of patient experience, caring and responsive are mixed, but we separate them. This is really about the organisation. Does the organisation arrange that you can be seen within a reasonable time? Does it arrange that when you come to the outpatient clinic, you don't have to wait for 3 hours to be seen? Does it make sure that if you do have to wait any length of time, there's a chair to sit on? Those are all things that are the hospital's responsibility. But it's also, more than that, it's also about how do we deal with particular patient groups, those with dementia, those with learning disabilities. So that's what we've got underneath that title. And then the well-led domain, this is something that's new to CQC. We're working very closely with Monitor and the Trust Development Authority on this, and we're working very closely with academics, particularly Professor Michael West, on this. The well-led domain is not just about the quality of the individual leaders, although they are very important. It's also about, does the trust have a vision and strategy? Does it have the right governance arrangements? In other words, would they know which the ward was that was in trouble or the service was that was in trouble? Have they got the systems that feed that up to the chief executive or the board? Then also, what's the culture of the organisation? So how do the staff feel? And there's a lot of talk about staff engagement. Actually, some of the very best trusts in the country talk about alignment between management and clinicians, because they are actually after the same purpose, which is about good patient care. And we do see that some places, and I have to say we see the opposite in others. And then it's also about innovation and learning, and we'll come back to that in a little while. Why have we gone for having a new approach? Well, frankly, because the old approach didn't work. We missed important problems. We missed problems at Morecambe Bay, for example. The whole focus was on this, are you compliant, are you not compliant, which is about meeting a fundamental standard, but nothing about anything beyond that. We certainly didn't get a picture of the overall quality of care. And I think one of the things that really matters about our new inspections is not only can we tell what the quality of the hospital is and the quality and safety of the hospital is when we go in, but can we understand why? what's really driving this? And I, believe you me, within a very few days of going into hospitals, we are able to do that. Equally, we tended to have our inspectors expected to go to a general practice one day, a care home the next day, a dental surgery, and then into an intensive care unit, and to be experts at all of those things. I don't think that's possible. So that was far too generic, and overall it didn't command confidence. There were good parts of it, particularly about the evidence gathering, and we've been very keen to retain those good elements in the new process. So I should say hospitals, which is in my job title. It was only after I was appointed that I found that hospitals included mental health services, community health services, ambulance services, and both the NHS and the independent sector. But I obviously didn't read the small print, or it wasn't there. But across all of those, the approach is broadly the same. And it's not that different, but on a different scale for general practice and for care homes. 3 phases: pre-inspection, inspection, and post-inspection. I'll briefly take you through those. First of all, we've got to select which trusts we're going to go into. And clearly, we want to go to those that we think are at high risk in some way or other as soon as possible, because then things can start to be put right. That's not the only criterion we've got, and I'll come back to it. Once we've decided which trusts we're going into in a particular 3-month period, we will start gathering data. Now, in the hospital sector itself, the acute hospital sector, we're fortunate. There's quite a lot of data around. So we'll gather data from national data sets. We'll go to the trust itself and say, we want information from you. We'll ask the CCGs and NHS England what they think of the trust. We'll talk to Monitor and TDA about it. We'll come to the Royal Colleges and say, have you got any reasons to be concerned? And I must say the Royal Colleges are very good at responding to that, so many thanks for that. We also go to the local health watch as well. All of that comes together as a data pack. And then at the same time, we start building a team for the inspection, which is a composite of clinicians, managers, CQC inspectors, and patients and carers. We call them experts by experience. And it's quite a large team for a hospital, as I'll come on to. Now, I just want to say a word about the data, because there are a number of data sets that we can look at. We can look at incidents from NRLS, for example. We can look at the number of never events, and we do. The reporting of serious incidents on STICE. We can look at MRSA and C. diff. We can look at staffing levels on individual wards as a marker of, is it likely to be safe? And that, of course, now is being put much more into the public domain. We do look at the mortality data. I know there's been a lot of controversy over that. What I can say about that is, when Bruce Keogh went into the 14 trusts that had high mortality, either on HSMR or SHIMI, none of them came out with a clean bill of health at all. In fact, 11 of them were then put into special measures. But we don't only look at mortality, and one of the other really valuable sources of information is national clinical audits. Personal view, we don't spend nearly enough on national clinical audits in this country. It's a paltry, single-figure millions or 10 million, 50 million maximum, and compare that with what we spend on other things. And I think we ought to be doing a lot more of that. And by the way, there is evidence coming through that participation in audits really does drive improvement in quality. I saw a very good presentation at the British Orthopaedic Association on Friday about how participation in the National Hip Fracture Database had driven improvement even before the best practice tariff came along. So I think that, which is really important. On the caring side, we've actually got quite a lot of data. CQC runs the inpatient survey, there's the cancer patient survey, we've got maternity surveys, and then also the friends and family test. So we can build all that into our process. Responsiveness, we've got all the performance targets, the 4 hours, the 18 weeks, RTT, cancer weights, cancelled operations, all of that stuff we've got. We can also look there, and one thing I haven't put down here, and I should have done, is we can look at complaints. And the complaints gives us quite a lot of useful information, may also tell us which part of a hospital we need to go and look at. And then on the well-led side, the staff survey is one of my favourite tools for knowing what's going on in a trust. The GMC trainee survey is great. It's got a 98% response rate. Do you know why it's got a 98% response rate? Because junior doctors can't progress to the next stage until they've completed it. I don't know what happens to the 2%. I imagine they drop out. But equally, things like staff sickness rates. If you see that a particular hospital has got a very high staff sickness rate in a particular department, let's say maternity, you can almost be sure there's going to be a problem there. And so it's a smoke alarm. We wouldn't make any judgment based on it, but we would then know to look. And we can also look at how, is the hospital taking appraisal seriously? What are the appraisal rates? So when we come to the inspection, it's typically at least 30 people, but please don't think we maraud around a hospital as a group of 30, and we tend to split into groups of 4 or 5 maximum. And when it's a very big trust on multiple sites, it may well be 50 or 60 people that form the team. The so-called day zero is our day when we get the team together, start bonding them as a team, planning the inspection. We've obviously done a lot of planning before they come together. We ask the trust to make a presentation about what they see as their context. Every trust in the country seems to be in the most impoverished part of the country with the biggest problems with the worst GPs and everything else. We take that with a pinch of salt, but anyway, and they've all got PFI debts. So we expect to hear all that, but we listen to them. And then also we ask them to tell us both what they think they are proud of in their hospital and what they see as their challenges. And we do encourage them to be open. On that same day, we hold a public listening event to get ideas from the public about the hospital, their views on it, and then we get stuck into the inspection. We clearly visit clinical areas. The staff focus groups are great. If you go to a hospital where 25 junior doctors all say to you, this place is fantastic, the management really look after us. The consultants are fantastic. It's great. I want to come back here at the next stage of my career, or preferably as a consultant. And I have been to a hospital, genuinely, where that has been said. You can be pretty sure that there are things that are good or even outstanding about that trust. And equally, we hold focus groups with consultants, with junior nurses, senior nurses, admin staff, etc. And we get their views. We constantly start pulling the evidence together. Towards the end of the inspection, we interview the senior managers, the chair, the chief executive, the finance director, medical director, nursing director, all of those. And then we come together as a group and we give provisional ratings, which I'll come on to. And then by the end of the inspection, we give an initial feedback to the chief executive and anybody else he wants there, he or she. And then we also normally would do an unannounced inspection a little while later, but we don't tell them when, of course. Within any trust, we've defined 8 core services, and we've deliberately done this to areas that are high volume and we think are high risk. So we will always go to the A&E department. The great problem we have with A&E is knowing what to call it, because should we be calling it A&E, should we be calling it the emergency department, emergency and urgent care? There's lots of debates about that, but actually everybody understands A&E. We go to the medical wards, including the frail elderly, and look at medical care, surgical care, including theatres, but also including orthopaedics within that, critical care, maternity and family planning, and increasingly we're moving on to gynecology as well, children and young people, end-of-life care, and outpatients. We can't go to every outpatient clinic, but we select those to go to. We can also always go to any other service we choose to, particularly if we've heard concerns. So if we've heard concerns about ophthalmology, as we did at one trust, we will make sure we go and look with care at the ophthalmology service. What do we do afterwards? Try and bring it all together, write the report, and that's no small task. Then once the report is drafted, it comes to a National Quality Assurance Group, which either I or one of my Deputy Chief Inspectors will chair, and that confirms the ratings, but the point of that is to try and ensure consistency, and consistency is our greatest challenge. Once we've done that, we send the report back to the Trust. They have 10 days to check it for factual accuracy. We try and stress to them that that is about factual accuracy, not about trying to argue with our ratings. we're sometimes successful with that. We do make revisions where they convince us that factually we got it wrong. We then hold a quality summit, and the quality summit, the idea there is to get all the local players together. So we present what we found, the trust responds, but then the local commissioners, the CCGs, Health Watch and others are all there, because what we want to do is get into action planning then. Who's going to do what? That's not technically our role, but we want to make sure it is actually happening. And then we are completely committed to transparency, so everything will get published. Ratings. This is the new kid on the block and probably the most controversial part of it. We rate not only each service but each aspect of each service on a 4-point scale. And the 4-point scale goes from outstanding through good to requires improvement and inadequate. Any of you who know about Ofsted will see that it's identical. And there is a science behind why you have a 4-point scale, because if you have a 5-point scale, apparently everybody always goes for the middle, the adequate that's in the middle. So we're trying to learn from Ofsted there and have the same approach. So what does that look like in practice? And this is the ratings grid, and of a particular hospital. This is a real example, and no reason I shouldn't tell you who it is, but just to take you through what's going on here. Across the top, we've got the 5 key questions we always ask. Down the side, we've got the 8 core services. And you can see that we are rating each and every one. There are a couple that we don't yet feel confident about rating. We're just about to be able to get to the point of saying we can rate the effectiveness of an A&E department. If anybody can tell me how to rate the effectiveness of an outpatient clinic, we spend loads of our time in outpatient clinics, but if anybody can tell me how to measure the effectiveness of that, I would be very interested. It probably isn't impossible, we haven't cracked it yet. But what I think you can see here is there is a lot of variation even within this one hospital. And to a certain extent it's got what we call the green cross effect. Down the middle line there, the caring, good throughout, and in fact one service was outstanding on caring, and across ways, at least one service, if not 2, in this case it happens to be children and young people and end-of-life care, doing very well. But you can also see there's really quite a lot of requires improvement, and one area that was judged inadequate within this trust. Now, I hope that will point the trust to where they need to be making their improvements. They can celebrate what they're doing on the good services, but they certainly need to move on with maternity and family planning, and the other areas there's a lot of work to do. Overall, at bottom right-hand corner, we rated that trust as requires improvement. So, what have we done so far? We've got around 66 acute trusts. That's about 40% of the total. We've done 12 mental health trusts out of 56, so we're about a quarter of the way, 20% of the way there. 8 standalone community health services, but also more and more there are community health services which are either attached to acute or to mental health trusts, so we're trying to do those together. We've just started on ambulance trusts. There are only 10 of those in the country, but we're learning as we go. So we're well underway. When we started on the acute hospitals, we deliberately started with a wave to learn from, wave 1, and we chose 6 trusts that we thought were high risk based on all the national data that we had, 6 we thought were low risk, and 6 that were somewhere in between. Partly, we were trying to test our intelligent monitoring tool. Partly, we were interested to see what the range of quality was across the country. Since then, we've done a further 48 trusts or FTs, and they've mainly been high-risk trusts, or those where concerns were emerging locally. We have done some that are aspiring to be foundation trusts, and we were specifically asked if we would repeat the inspections for all of those that have been in the KEO review last year. What do we look for within each of those cells on the grid? Well, we've defined key lines of inquiry and that we will always check out. And we've deliberately given ourselves prompts or subheadings within our reports. And this, again, is about maintaining consistency. So if we've asked about the WHO surgical checklist in one trust, we ought to ask about it in every trust. Another example, something that I hadn't considered when I started. How many patients go to an outpatient clinic and their records are missing? Actually, there's safety issues in that. If you turn up and people can't access the data, it's all right maybe if it's all electronic, but there are relatively few hospitals that are at that point yet. And we've found trusts where 25% of people attending do not have their medical records when they turn up. Now, I think that's a scandal. And we've made it very clear to the particular trusts that they need to do something about that and quickly. And we will go back and check that they have. But that is a sort of a prompt that we hadn't thought of when we started, but we now ask in every trust we go to. And this, I'll romp through this, but it's really to show that even within safety, there's an awful lot of questions that we need to ask. Clearly, looking at the level of incident reporting and more reporting, we generally judge to be better. But it's also more than just are they reporting. It's are they learning from it? Do staff at the front line get any feedback? And again, it comes out in the junior doctor focus group. Do you ever report incidents? Well, I did a few, and then I got no feedback at all, so I've actually stopped doing so. Now, that tells us a lot about the trust's approach to safety, whereas there are other trusts that are much more proactive. We also ask about, we observe the cleanliness, we've got the infection control figures, and we look to see, is there any hand gel? In some places, there isn't. And they know we're coming. I mean, it's extraordinary. I mean, how can they be so stupid not to have their hand gel filled when they know that we're coming? It might be different on an unannounced inspection, but not when it's announced. We look at the environment. Are there buckets holding, getting the drips? Is the equipment up to date? Has it been checked? And when was it last checked? And when it was last checked 3 years ago, is that really adequate? No. Medicines management. Very important, and there are lots of different aspects to that, of course. Records and record keeping, safeguarding, and particularly important post Jimmy Savile, but we ask that on all the services that we look at, and are people getting the safeguarding training that they need? A mandatory training generally. The management of deteriorating patients, this was something that very definitely came through from the Keogh review. First of all, what early warning scores are they using? Secondly, what processes have they got for escalating? And thirdly, what do they then do about it? And the critical care outreach teams. I think critical care outreach teams have been an enormous step forward over the last 10 to 15 years. But some trusts have got this. And then things like care bundles, the sepsis bundle or whatever. How quickly are they getting people treated when they are deteriorating? And we always look at nurse staffing levels and medical staffing levels as well. So that's quite a lot just for one domain. I won't go through the other domains in as much detail, but this business of our trust giving effective care, are they making people better? We certainly ask about, are they following NICE guidelines or the equivalent, and what's the evidence that they are? And we also look at the other things there. But the patient outcomes. We can't determine whether a trust is producing good outcomes just by walking around a trust. This is one thing we desperately rely on data. And this is, again, where the clinical audits come in. But we also do ask about multidisciplinary team working, you'll be surprised to hear. And we do also look and see how far they are on the trajectory towards 7-day services, and that varies. And it's not just that it can be done in larger hospitals and not smaller hospitals. There are some smaller hospitals that are a long way down the line. We observe care. And again, you'd think that when we were there, it would be easy. But it's amazing, if a call bell isn't answered and we're there, why not? And we also have techniques of actually observing care specifically so that we can gather the evidence. Responsive. are they planning services that are suitable for their local population? If they've got a Nepalese population, are they catering for that Nepalese population on their doorstep? The particular hospital I'm thinking of does. Access and flow. How are they managing patients through the hospital? Are they meeting people's needs in terms of dementia, learning disabilities? How good is their complaints process? What are they doing about it? Are they learning from it? And then on the well-led side, I mentioned some of this already, but it's important to say we're not just looking at the trust level, we're looking at all levels, and we're looking at all of those things to make sure that those are being done, because we really do believe that there is a link, and this is evidence-based, between a service being well-led and getting good quality and safety. So, what have we found? I'll give it under 3 headings. We found variation, we found a few cross-cutting issues, and then there are some comments about the individual services. The headline answer is the degree of variation between the best and the worst is large, and frankly it is unacceptably large. We have a national health service. You'd think we had the same quality throughout. If this was Sainsbury's or Tesco's or any of the other supermarkets, when you walk into those, you expect, roughly speaking, the same quality in any one of them. That is not the case in the NHS. What we're seeing is that there's variation between trusts, between services within a trust, as I showed you before, and sometimes it's even within individual services. So that we may, on the medical wards, we may find that there's one ward that's really severely off the pace, while others are actually doing perfectly okay. So just to give you an example of another couple of trusts, this is Basildon. Basildon was a trust that was in special measures and has made a remarkable progress, and this is how we rated it. You can see, okay, there were some problems we found in surgery. There were a couple of problems in safety, so we said overall that the safety does require improvement, but overall far more green and blue than yellow, and we decided this was overall a good trust and had made remarkable progress in a quite short space of time. A rather different picture. Wexham Park Hospital, and I'm not going to go through this, but you can see that there's an awful lot of red on that grid, but within that, look at children's care. Children's care good throughout. So somehow the children's service had managed to isolate itself from the mayhem of the rest of the hospital and was providing good care. And well done them for achieving that. And intensive care nearly got there. So one of the things we found, if we look at the caring column, far more good than not good. And all our teams come back saying that compassionate care is alive and well in this trust or that trust. And there are very, very few exceptions to that. The exceptions are where, frankly, people are overwhelmed. The staff are overwhelmed, usually because there is a combination of inadequate staffing levels and inadequate leadership. This tends to be on frail elderly wards or so-called escalation wards. Those are wards that are opened in response to, let's say, winter pressures, and that can cause problems. What have we said about staffing? Actually, interesting, most core services were adequately staffed. I'm not saying well staffed, I'm saying adequately staffed. Not everybody has been using acuity or safer staffing tools. That's changing rapidly, I think. It was A&E and medical wards are the most frequent areas not to have enough staff. And there are lots of reasons behind not having enough staff, and I've just given a few of them there. And a lot of places are now recruiting in Spain and Portugal and elsewhere to try and get the staff they need. The term flow was really not in the medical language a decade or more ago, but it's now very commonly used. It's how people move through the hospital, and there are multiple hold-ups. When we look at the A&E 4-hour wait, it's not all A&E's fault that it's not there. It's often that the medics are not pulling the patients out of A&E onto the acute medical unit, or sometimes the surgeons. It's also how you get from the acute medical unit to the medical wards, from critical care onto the ordinary wards, from wards to discharge. Now, this often results in medical patients being on surgical wards, which can lead to problems. Particularly, you hear people talk about safari ward rounds, trying to find their patients. They can lead, from the surgical point of view, it leads to surgeons having to cancel operations. It leads to multiple moves for patients, which is not good. On the other hand, some are dealing with this very actively. I'm fascinated by the culture within hospitals. It's very difficult to define it. It is quite easy to recognise it. We have the evidence from staff surveys and sickness levels, as I've said. We have seen some that are truly open and learning. In others, it's very much a them and us between management and clinicians. Some are really taking active steps to improve this. Now, just a few figures. The 38 trusts that we have rated so far, we've reported on more than that, but we didn't rate them all at the beginning. Remember, we have skewed our sample to those that are not expected to be good. So of those, we've reported 9 as good, 24 as requiring improvement, and 5 as inadequate. And where within the trusts are the problems? Well, actually, safety is a big problem. That if you look at the proportion that are good or green, it's only just over 20% that we've rated as safe overall at a hospital level. And that's far less, for example, if you take the third line down, the caring, where the vast majority we've said are good there. So I think just that contrast tells you a lot. In leadership terms, we're also saying there's a long way to go to get good leadership. And this is not just at the trust level, but this is at the service levels contribute to that finding. So there's a long way to go for this lot. Where are we seeing the differences by core service? Well, if you just look at the good end of the scale, intensive and critical care. And the one thing I'd say about intensive and critical care is they know their data. They almost all, there's a program called the ICNARC program about critical care. They all know it. They're all proud of it. There's only about 2 hospitals we found that aren't participating, and so at least we've got good data there. But they're also very good on the caring side as well. So they come top of our list at the moment. You can see the others, and you can see that it's most often A&E that we've actually judged to be inadequate. These are only early numbers, and as I say, it is a skewed sample, but I thought you would at least be interested to see that. So what are my reflections finally? I do think this approach is more robust and credible than anything that CQC has done before. What do I base that on? Well, actually, most of the trusts that we go to tell us so, and we've also had an independent evaluation that's confirmed that. It hasn't said that everything is fantastic, it isn't. We are still on a learning curve, and interestingly, we've just started going back to some of the trusts that we saw in our first wave, and we know that we are better than we were then, much more precise, granular, and much more able to defend any rating that we give. But consistency is a huge challenge, and you can understand why when we have to synthesize all that evidence that I showed you before. How do we do that? Well, first of all, we want to recruit good teams. So any clinicians, managers amongst you who want to come and join our teams just for 3 or 4 days, you're very welcome. Or anybody that's an expert by experience, welcome as well. We then have to train people. We have to have consistent methodology. We need to make sure people are trained in it. Then the quality assurance group, which I chair normally, that is an important part in this. And then, of course, making sure that the trusts have the opportunity to challenge. So I'm going to end there by saying I think we've come a long way in the last 14 months. It is better than what we've done before, but we know we've got to go on improving. And we've got to go on improving because as we get better, expectations of what we do increase as well. So advice and comments genuinely always welcome. Do please consider offering your services. Thank you very much.
for a very clear and very thought-provoking presentation on where you are. I'm going to take some questions now, but can I be really cheeky and take Chair's prerogative to ask you the first question? I was really struck by your slide showing that safety seemed to be the biggest challenge. And obviously, we've got lots of patient safety researchers here in the room. I was wondering, it's possibly a tough question, but if you had any thoughts on what were the main research questions for us as patient safety researchers?
Well, you can all come and help us distill our own data, because we haven't mined it sufficiently yet. And actually, it's all in the public domain, so it's all available. Because you're absolutely right. Within that, we need to get much more specific. Within safety, how often was it about nurse staffing levels? How often was it about failing to do the WHO checklist? How often was it medicines management or records? I haven't actually got that data yet, so let's work with you. And you know, there's bags of material there to do, and that will also help us to get better at making sure we ask the questions in a consistent way and that we report in a consistent way. It's all of the above, by the way. I mean, it's not one or other, but equally we need to look and say, within A&E, is it usually this or is it usually that? Within critical care, what is it normally? So we are generating a lot of data.
Well, I'm sure there's many of us that will be very interested in working with you to look at that in more detail as we go forward. Now, questions. Could I have 2 volunteers to take the roving microphones to our questioners? And we've got a question over here, but I think the gentleman at the back is first. Thank you. And if you could just wait for the microphone, if you don't mind, so that we can all hear you.
I enjoyed your presentation. I think the new inspections are a sea change compared to before. I was naturally disappointed that you didn't mention the word whistleblowing once during your presentation, and you may want to comment on the Francis review into whistleblowing. I mean, I take the view that, and I've written an article on this, that a well-led the CQC doesn't have the resources or the expertise to look at that, and you need a staff support a commission to do that separately and look at issues such as whistleblowing. If I could just make a couple of specific suggestions. You mentioned the staff survey. Staff surveys are by themselves flawed. They're voluntary, and only a certain number of people respond to them. If you take past staff who no longer work there, they'll give you a much more honest view as to what the place is like. People who've been through grievance hearings, etc. And I'd just like your comment on a specific methodology, in that of mystery shopper, and that's been used in the States and in this country as well, and what your comments on are on that surreptitious monitoring.
Firstly, on whistleblowing, I should have mentioned whistleblowing. Whistleblowing is one of the key elements that contributes to our intelligent monitoring, and the fact, I suppose the reason I forgot to do it is because whistleblowing can actually be about safety, effectiveness, caring, responsiveness, all well led. It crosses the domains. We take it extremely seriously. And we always offer to meet with whistleblowers to try and hear their concerns, because that may help us to know how to inspect a trust. And we have done more than one inspection already, largely driven by the fact that we were hearing concerns from whistleblowers. So my apologies for not putting it into the talk, but it really is an important part of what we do. The staff survey, we will use the data sets that are available to us. The staff survey is actually very good, and it does, you know, I know it's voluntary to respond to it, but I can assure you that it discriminates between trusts, and it discriminates with trusts, and we then corroborate what we're hearing from the staff survey with what we see and what we hear on the ground. And I've yet to see a trust that performs poorly on the staff survey where on other factors the team have come away saying all's well with the leadership of that trust. And so I'm not saying we shouldn't think about previous staff. I'm very happy to do that. It's quite technically difficult to know how to access them. So we go with the survey we've got, but we're open to suggestions about how that could be done. You're not the first person to suggest mystery shopping to me. Again, I'm not opposed to that as an idea. At the moment, by non-mystery shopping, we're certainly able to tell the difference between the inequality between trusts. So I don't, if and when everything gets to a stage where we think it's good, maybe we need to add the mystery shopping into it. I can tell you, people trip themselves up without needing a mystery shopper.
Thank you. Right, the next question, Jeremy.
Yes, I'm Jeremy Myerson. I'm from the Royal College of Art next door, where we have a big focus on design for patient safety. I just want to ask, in your inspections of hospitals, when you're looking at things like culture and flow, how much consideration do you make of the state of the built environment, the designed environment? And how do you get feedback in staff surveys on what staff think of their physical environment?
To the latter part, I don't think there is a question that I can remember in any of the surveys that I've looked at that relates to the physical environment. We clearly we always look at the physical environment, and we will always comment on it, or we will always comment on it if it's not suitable. And I suppose the area where that's most common at the moment is in A&E departments, because the A&E numbers have gone up so much in the last decade that even if the place was built 10, 12 years ago, often that was, the number of times we hear this was designed for 60,000 people going through and it's now got 125,000 going through. And that's clearly true. We can see the figures. And then we see people working in very cramped environments, and all the pressures that are on them. And sometimes that can have safety. When people are then having to be looked after in corridors, or in one place I can think of where there seem to be two bays in an A&E sharing the same oxygen. Now that far from ideal. And so yes, we do look at it. But again, if we can look at it in a better way, and any advice on that, open to suggestions.
Did you want to just pick up very briefly on that before we go to the next question?
I really enjoyed it, and there's no question you've gone a long way since our previous CQC inspections. But I'm sure when you go to bed at night, your biggest fear is, through this system, we may get one organisation that will get through.
Yep.
And we're back to square one in terms of the big hoo-ha that's happened previously. And so, acknowledging that there is a process of calibration, you yourself said it, our inspections now are better than the first few we did. And I'm sure that learning will improve and improve. What are you doing to validate this in terms of the methodology, the face validity of this, the reproducibility of this, in terms of the future, to probably giving you, well, in many ways, make you sleep better?
I sleep very well anyway. Maybe I shouldn't, but I do. Yes, but you are right that there will come an occasion where we have missed something. I hope we can get as much in the bank before that happens as possible. My real fear was that was going to happen in the very first phase before we'd got enough experience, and we would be blown out of the water very, very early on. I think it will depend as and when it will happen, and it will happen. It will depend. Did the trust know about it but not tell us? In which case, okay, how could we have screwed it out of them better? But ultimately, it is their responsibility to be open. So were they being open with us? Or was it a service that we're not yet inspecting? That's a second possibility. So because we've chosen this core service model, we're not in every part. So give the example I gave before of ophthalmology. If we hadn't picked up anything about ophthalmology and there was something really terrible happening in ophthalmology, we might miss it because we're just not inspecting. Or Worst case scenario is it is in a service we've inspected and we should have picked it up and we didn't. So I think there are slightly different implications each way, but it will happen. I'm almost sure. I think what we've got to try and do is minimise the risk and it's the multi-pronged approach that I think is most likely to protect us from that.
Okay, and I'll take the next question at the back. Thank you.
Thank you very much. Very thought-provoking. I'm not sure this is working. Okay. Thank you very much. Very thought-provoking. And I'd just like to pick up on, I'm a paediatric intensivist working at St Mary's.
So children and intensive care, yes. You must be all right. Yes.
So we've just had a CQC inspection, as
so
I'm
you
sure
have.
You know. And one of the things the Trust got very fixated on was where we were in the national rankings for the mortality data. And you talked about the ICNARC data, and there's a similar thing for paediatric intensive care called PICANET. And I guess my question is have we as a nation become too fixated on these on ranking? Because of course when you look at mortality data in relation to severity of illness, which we do quite well in intensive care, what you get is a funnel plot with number of patients treated on the x-axis and standardised mortality on the y-axis. And what you want to see is you're somewhere within the 95% confidence intervals. And if people try and rank us on that, then we're going to be back into the old problem of 50% of the hospitals are performing below average, which is a kind of meaningless observation and doesn't really help anyone very much. So I just wonder how you get around that and how we think slightly more intelligently about ranking ourselves, particularly in relation to those kind of statistics.
We don't go by ranking. We hope, but understand funnel plots. And so we will be, and ICNARC is a perfect example, and I'm sure PICANET is as well, because if people are within the funnel plot, that's fine. And we don't try and rank. What really is useful to us, and we can only do this with the support of the professional societies, is where, let me give stroke as an example, where the stroke audit, they have said, these are the key elements: getting scanned within an hour, getting onto the stroke unit within 4 hours, having intensive physiotherapy and rehabilitation, thrombolysis rates, 4 or 5 different measures. In that audit, they have combined those so that they do group trusts into A, B, C, D, and E. Now, that's come from professionals. That's not me saying I think this is wrong, but that's very helpful. So if I see that this service is E for stroke, it's very unlikely that I'm going to say that that is good for effectiveness. So that is a very useful combination, and I would be very keen to work with paediatric intensivists or anybody else to say which are the most important things from your particular audit, how can we combine those so that we can get some idea of the span. By the way, in the stroke audit, I don't think there are any that are currently rated as A, so it's currently skewed lower, so that there's room for improvement.
I think we've got time for just the one more question. I know this gentleman here was next. I'm very sorry. I know there's lots and lots of people wanting to ask questions. Do you want to go ahead?
I heard you on your appointment outline the aspirations that you fulfill, so I applaud you on the big changes that you brought to CQC. But one of the other aspirations of inspection is to try to foster within hospitals ongoing self-assessment and continuing improvement programs. And there's been a lot of debate in the NHS press, blogging and academic, about the value of inspection versus, say, peer-reviewed license accreditation schemes, which I've been involved in other countries and which involve teams for months and months in preparation before the reviews. I mean, you've commented today, they know we're coming and still they do this. Can you please comment on what you think inspection can do to foster in-institution learning programs, development, continuing self-assessment and improvement?
Well, one of the things I hope is that the suite of metrics, the suite of areas that we're looking at will become well known and well established. I set out the slides of all the things we look at under safety or all the things we look at under effectiveness. What I would hope is it's not just us going around compiling the safety record or the effectiveness record for a trust. They'd start doing it themselves. And so when I go into a trust and they say, here is our effectiveness dashboard, wouldn't you like to know that we are E for stroke, but we are A for GI bleeds, and we are best in the country on the hip fracture audit, and we've got it all there, so we know we can present to you how effective we are. There's not a trust in the country that can do that at the moment. I hope in a year's time there are going to be quite a number, and I hope that we can agree which are the key audits which we would want to see on a dashboard. So we have a safety dashboard, we have an effectiveness dashboard, a caring dashboard. We are then able to say, yes, why shouldn't they self-assess? I would love it. And the trust that comes back to me and says, actually, Mike, we've got a better one than yours. Fine, great. We'll probably plagiarise it. I mean, why not? I think if we could see that was being done, and that equally, you go into a trust and they say, Mike, it is Ward 32. We know it's Ward 32. It went off 2 months ago. We know why it went off, because somebody went on maternity leave. We've got in there, we've put the right things in, and you can be assured that within another 4 weeks it'll be back up and fully functional. Fine. We will take that into account, because they know what's going on. Their governance systems are in place.
Great. Well, thank you very much, Professor Richard, and to everyone for the discussion and debate.